that was a very good segue, I think, into perhaps moving on to Dr. Moreira's talk now. Thank you very much for your excellent talk today, Dr. Kudumi. Could I now reintroduce Dr. Daniel Moreira, who is at St. Jude's. His talk will be on early diagnosis, but his particular interest, as Dr. Kudumi has said, is on medical education and presenting novel ways of making people aware of the issues related to brain tumors. And the improvement of outcomes of children with cancer in low and middle income countries is also a very significant focus for him. So thank you very much, Dr. Moreira, for talking to us.
Thank you for the introduction or reintroduction, and then thank you for the invitation to participate. Hopefully what we'll cover in the next 30 minutes or so will complement a lot of what Dr. Kudumi was mentioning, and hopefully we address all the things that he mentioned I would talk about. So these are the three main themes that we'll cover. A general concept of pediatric neuro-oncology care across the world, general concept of workforce and education, and then an introduction to some of the educational efforts that we have at St. Jude Global, specifically going over a course that we ran a couple of years ago and that we are just rerunning as of January of this year. And I saw in the audience at least 3 people that participated in the last course, including 2 fantastic neurosurgeons, Dani Campos from Peru and Luis Arredondo from Mexico. So we know, based on population-based cancer registry data, that over the past 40, 50 years that the outcome of pediatric CNS tumors have improved, and this is probably linked to better radiologic infrastructure, better pathology, better neurosurgical capacity, and also the optimization of adjuvant therapy like radiotherapy and chemotherapy. And these are 2 examples based from SEER data, medulloblastoma and ependymoma. We see about a 30% increase in net survival at 5 years. And then when we read textbooks, we frequently hear this idea of pediatric CNS tumors are the second most common cancer. And this is really the experience from high-income countries. But if we look back at population-based cancer registry data from across the world, this is actually true. And CNS tumors represent about 20% of the new cancer cases in children, either 0 to 14 or 0 to 19. And you see in this kind of purplish color, the burden of newly diagnosed CNS tumors. And then if we think about not just the incidence, but what is the burden of children with CNS tumors worldwide, we anticipate that every year, anywhere between 30 and 40,000 children are diagnosed. But unfortunately, about 50% of those will not survive their disease. And if we look at these figures, and this is data from GlobalCan and the Global Burden of Disease studies, as expected, the burden of both incident cases and death is skewed heavily towards low and middle income country, as is the general population, but we see a marked higher rate of deaths in low and middle income countries. Returning to the concept of incidence, if we segregate the countries across the world in the World Bank tiers, those 4 tiers that exist, high income, upper middle, lower middle income, and low income, we see that the incidence is significantly lower in low and middle income countries, with really a positive data in low income countries. This is based on cancer registries, which in low income countries are present only about 10 to 15% of countries. And the other thing important to note is the proportion of CNS tumor to the total burden of childhood cancer is also lower. So there's obviously barriers in terms of diagnostic capacity, but also registration practices. It's unlikely that this is due to biologic consideration, although competing diseases like infectious disease could be also an important factor to consider. Then we always return to this concept of LMICs versus high income countries, mainly because there's a very close correlation of the GNI or the GDP of a country with how much a country spends on health. So this is a nice study from the Lancet from about 8 years ago that goes over some of these factors more in depth. And when we think about pediatric CNS tumors, it's obviously a complicated universe to dissect. I think Dr. Kadumi, Dr. Buffet alluded to a lot of these concepts. Obviously, if we think of this ecological model, if we start off in the left, a child will eventually develop symptoms from their brain tumor, but they have to be engaged in the healthcare system or the health system. So they have to be evaluated by that first contact physician, that first contact nurse practitioner, nurse, whoever that may be. And there has to be that big step in terms of suspicion that the symptoms are secondary to a brain tumor. Then once that happens, there has to be the capacity to actually diagnose it. That is dependent on systems of referral and counter-referral, availability of diagnostic services. If a biopsy or tissue diagnosis is required, then that has to be available. And then obviously all this dependent on infrastructure resources. Once you have that diagnosis, which will hopefully be correct, then the patient has to have access to the correct treatment. This is obviously in pediatric neuro-oncology, access to neurosurgical capacity, radiotherapy if it is warranted, and then chemotherapy, not just any chemotherapy drugs, but the correct one with the adequate quality. And that will lead hopefully to not just survival, but with quality of life. And that is also dependent on the availability of supportive care. So this is obviously a complicated element and a complicated disease course, obviously all within the realm of availability of workforce, them being having the correct skills, knowledge, and competencies, having the adequate communication, and also ultimately having quality care at the essence. So then we try to dissect some of these things in terms of diagnosis and treatment. We see, as we have mentioned with incidence, there's massive disparities in terms of access to services. This is data from a couple of years ago looking at only the OECD countries, and we see a marked variability in availability of advanced imaging like MRIs on the left or CT scanners on the right, anywhere from about a 20-fold difference for MRIs to almost a 30-fold difference for CT scanners, anywhere comparing Mexico to the frequency in Japan. And then, as is well known to this audience, the availability of neurosurgeons and specifically pediatric neurosurgeons is a big barrier for quality care. And we know that there is an inverse relationship between the number of procedures done by a surgeon and the mortality rate. And that was published a couple of years ago. And then specifically for pediatric CNS tumors, the reported rate of gross total resections varies widely based on the available literature. This is obviously skewed towards upper middle income countries and probably more positive outcomes, but obviously linked to experience as well. And we see a lot of the same things also for pathology, market variability in terms of access to pathologists, but then there's also the question about infrastructure. What are the availability of basic stains, immunohistochemistry, and in our modern world, what is the availability of molecular tests as well? Radiotherapy is a big barrier to care. On the left is a figure from the Lancet Commission on Radiotherapy, where we see that countries in Central Africa have no access to radiotherapy. This is a couple of years old, but unlikely to have changed significantly, and that is availability, just the infrastructure, but then there's the question about quality of as well. And there's a report from Pediatric Blood and Cancer that described deviations of delivery of radiotherapy in one country in Central America. So if we go back to this, obviously a lot of different factors that are complicated, and really, to be honest with you, for the most part, outside the realm of clinicians. That doesn't mean we can't influence them, which is why this is very important. Dr. Buffet mentioned it in his talk, and this is the Global Initiative of Childhood Cancer. This is a WHO initiative funded by St. Jude, and there were many a discussion, but I was lucky to have been part of the discussion that picked the 6 index cancers, and we have 6 cancers that represent the comprehensive nature of pediatric cancer care, and low-grade glioma was proposed, because of its reliance on having a connected health system, systems of reference and counter-reference, the availability of multidisciplinary specialists like neurosurgeons, radiologists, pathologists, oncologists, but also rehabilitation services, physical therapy. And so that is why this WHO initiative has access to pressuring governments for investment. And at the end of the day, this initiative is seeking to save 1 million lives by 2030 by increasing the survival rate of these pediatric cancers to 60% by that year. So when we think about health systems and how we can link care and available services, health systems are frequently divided into these 6 building blocks. And this is a publication from more than 10 years ago, but still very relevant. And when we think about the patient that we have in front of us, if we're in the OR, we're providing post-operative care, we frequently are in the realm of service delivery. And that is about availability of OR time, of OR infrastructure, of systems of reference, and that kind of direct patient provider interface. But there are 5 other things that are very relevant. This is where we typically are in the patient care realm, but we have to think about the workforce. This is one of the 6 building blocks to a functioning health system. And when we think about the importance of the health workforce, there was a publication from the WHO, and I love the title. It's very clear, but it is very poignant. That there is a universal truth: no health without a workforce. And when we think about the workforce, it's not just about number. It's about the right number of specialists, and that includes a multidisciplinary care, but where they are also distributed. Are they all centered in one single referral tertiary center or 4th level center in the capital, and they're all concentrated there? That is very different as a more homogeneous distribution across the country. So those talk about availability, number, and accessibility, which is distribution. And then relevant more towards the realm of education is, what is their training like? Do they have the knowledge and the skills, the competencies to provide high quality care? And that relates to quality and acceptability. And when we talk about education, ultimately, through educational programs, through educational initiatives, the end goal of an education system in medicine is to provide the population with the health professionals with the adequate competencies. Obviously, there's links in different realms, both at the population level, but also at the labor market. And this is something that we cannot forget when we are engaged in trainee programs, right? There's not much point in training hundreds of pediatric oncologists if the job market is saturated and they will not be able to practice their newly acquired skills. So we have to remember what is the population needs and addressing those through our educational system. So when we think about educational intervention for pediatric neuro-oncology, these are some very general thoughts. There's obviously the realm of clinical management, and here I think we have to think about risk-adapted care and keeping at the essence the idea of curing the curable, right? And optimizing our resources in that way. And also resource-adapted care, right? We don't want to provide services that provide care that is outside of the realm of the available resources in terms of supportive care, for example. Here, this is more towards looking to the future, is how can we integrate novel technologies, right? Dr. Cohen described very nicely how the field has transformed a little bit ago, and how can we use that information to leapfrog, for example. An example that I frequently use is, for example, Wnt medulloblastomas, right? They represent a fraction of medulloblastomas, but they have a very good prognosis. So can we leapfrog using molecular characterization and de-intensifying therapy if we identify those prospectively? So this is an idea that we can think about as well. Like Dr. Kadumi just mentioned, how can we optimize the clinical management for the detection of brain tumors? And this is both for non-specialists like general physicians, like pediatricians, nurse practitioners, community health workers, and also specialists like ophthalmologists or GI specialists who are performing scopes on people with recurrent MSF. Outside of the realm of clinical care, but this is in the realm of more global and public health, is what are the skills needed to perform research? We need to know what is our current status so we can identify valuable interventions and prioritize those interventions. Also thinking about quality improvement skills and identifying those strategies and monitoring those over time. And there are more novel area of research is implementation science. And this is really, how do you need to modify and adapt interventions that have a strong evidence base in different contexts? Specific for pediatric neuro-oncology, always important to mention that this is obviously a team sport and multidisciplinary care is required for these patients. And here is where team-based learning can be a way to address that. This is a way that we can galvanize teams and create more consolidated team dynamics and better communications. And always in any intervention, always key to have monitoring and feedback strategy. That way we know that our evaluation is defined at the beginning, so we can see if our interventions are actually worthwhile and they can be tweaked over time. In terms of possibilities of realms of education intervention, there's always the clinical training programs like fellowships, like residency programs, and there's a nice amount of literature specifically for pediatric neurosurgery in the LMIC context, and these are some publications related to that. And then there's also this possibility of telehealth and international partnerships, and both Dr. Kadumi and Dr. Buffet mentioned using this as significant leverage as a mechanism for training and education. Here are a couple of papers describing the massive possibilities of this, and over the past 2 years, we have seen how teleconferencing and Zoom and WebEx is a massive tool to be leveraged for communication and transcontinental care. And then going a little bit into the St. Jude global programs, our educational initiative is key to the global health intervention that is born out of St. Jude, and it is coined as the St. Jude Global Academy. There are different educational opportunities with two main buckets. One is the Global Scholars Program, which is basically a master's in science, which is a partnership with the newly launched St. Jude Graduate School of Sciences, and then the Global Professional Education Program, which has different work streams, and I will touch on distance learning very briefly, and then training seminars. Naren mentioned at the beginning of Dr. Kadumi's talk the visitors program that unfortunately has been disbanded, but it has been to some degree recreated in this training seminar approach, which we think is even more valuable and is more structured. And I'll go over a course that we ran a couple of years ago. So when we think, and this is a little bit of educational theory, when we think about the hierarchy of medical education or medical education interventions, there's the level of cognitive impact. You know something, you know that low-grade gliomas are the most common tumors in children. That is valuable, but even more important is what do you do with that information? What is your behavior based on the knowledge that you have? And this is a big step, right? And this is where clinical experience and clinical expertise comes into play. But that is really what we're trying to get at when we have an educational intervention, not just people knowing more, but they actually apply that in their clinical practice. And that is where changing behavior is what we want to achieve with a lot of our educational intervention, at least from the St. Jude side. Yes, we want to concentrate on providing opportunities for advancing knowledge and skills. Hopefully that builds on clinical competencies, but ultimately the next step is, how does that change behavior? Ultimately, and this is indirect and this is down the line, but how does that change the outcome of the patients that people are seeing? And that is really what we're trying to get at. And that is really that linkage of educational programs with the needs of the population. So we'll talk about those two things briefly. Distance learning, we know access to educational content is key. And that is obviously during formal training programs, but also just like this forum, professional development and continued medical education over time. Access to information is key for knowledge, especially more recently in our field where everything is so dynamic and there's new classifications coming out, there's new diseases being described, novel treatment strategies. So this is key. And this is where distance learning can come into play. Obviously, an increasing amount of online resources exist, and that these are specific to neurosurgery, pediatric oncology, and these are in the form of written content, I think more relevant for surgical specialties, video libraries, and also an area that is a little bit more novel, simulation-based opportunities as well. At St. Jude, we house Cure for Kids, which is a distance learning platform that has been around for about 20 years or so. We have 60,000 registered users, closer to 10,000 users that are active. We have about 50,000 content views per year, and we house also a integrated meeting platform, and we host about 2,000 meetings per year. Over the past almost 20 years, we've had about 1.9 million views to our Cure for Kids website, and this is specific for pediatric oncology. So there is some content for pediatric neuro-oncology, and with our fortune of having Dr. Booth joining us, we hope that more content will be relevant for pediatric neurosurgery. And this is a map of where our users are, heavily skewed towards the Americas. And then I'll go over this training seminar experience that we have from a couple of years ago. And this was an idea that Dr. Kadumi had. And then when I joined St. Jude, together we worked on how to best optimize this educational opportunity. So the core concept that we had for this course was that it would be hybrid or blended, that it would have an online component that would be leveraging Cure for Kids, but also have an in-person component, which is really more about that direct interface, consolidating the knowledge required on the online component. We wanted centers to participate as teams, kind of understanding that multidisciplinary teams are the key towards a successful pediatric brain tumor program. And then we wanted to concentrate on centers with the capacity to treat CNS tumors. This was knowing that centers, for example, in low-income countries may not have access to radiotherapy, for example. And then the other thing that we wanted to do is define the curriculum in a systematic way. When we want to come up with a course, usually as physician, as medical educator, we typically want to jump to the content. We're going to talk about ependymoma, we want to talk about medulloblastomas or hygrogliomas, but that is, even though historically done and still done currently, that is not the best way to optimize medical education intervention. There's a little bit of a systematic approach to it. This is the model proposed by David Kern out of Johns Hopkins. And it really includes a very logical step. There isn't anything massively groundbreaking, but it's really based on that idea from the Lancet Commission on Medical Oncology. What are you trying to achieve? What is the basic population need that you're trying to achieve? And what are the needs of the target learners or the target participants? And this is in the realm of pediatric neuro-oncology, where we don't have much data in terms of service capacity. These are two papers in the last 10 years or so that described in some way objective measures of brain tumor service capacity in LMICs, a paper that Dr. Kadumi led and the paper that Dr. Finley led, and that was based in Paraguay. So what we tried to do was to design a comprehensive assessment of both neuro-oncology capacity, but also educational goals. So we designed a survey that had about 100 questions, identifying elements of these 11 domains that looked at health systems, basically the system of reference, encounter, referral, workforce availability, imaging infrastructure, pathology, neurosurgery infrastructure, medical infrastructure, which is more related to access to chemotherapy agents, radiotherapy, the multidisciplinary dynamic as a marker of care, identifying how CNS tumors are treated, but also looking at patient outcomes. Specific for learners, what were their educational goals? So based on those 11 domains, we sent out this survey to 24 centers across the globe, and within about a week to 10 days, we actually had answers from all 24 sites. These sites saw about 50 new brain tumors per year, and this is based on 19 of the 24 have an actual hospital-based cancer registry. When we asked them about predicted outcome of pediatric brain tumors. There's a variability anywhere from 0 to 19 to 60 to 80%, and that is a frequency in that histogram on the right. And then if we compile this data and distill it, what we found out was that centers had the necessary elements to treat, and this was skewed towards middle-income countries. So they had workforce, they had medications, and they had infrastructure, neurosurgery, radiotherapy. And when we looked at barriers to care, delays and abandonment was the most frequent one. We also identified a low estimated gross total resection rate at just about 2/3. And then the other thing is poor communication between teams, the inexistence of tumor boards. When we asked about possible solutions, communication, collaboration, education were the three most commonly cited elements. And then when we asked about education goals, it was more about disease-specific topics, learning about medulloblastoma or DIPG. This is obviously, in terms of solutions, slightly skewed because we were asking these questions in the context of the possible education intervention. So I think we have to take these answers with a little bit of a grain of salt. So based on that survey, we identified themes, we defined the content, and we finally created the content. These were the 5 themes that we identified: the current landscape of pediatric cancer care. This was talking about burden estimations, the importance of cancer registries, and then tools of change, which is kind of general concept of global and public health. Diagnosis and treatment of the different types of brain tumors, comprehensive care, which is basically this idea of multidisciplinary care and cohesive and effective teams, research and quality improvement, which is basically skills that we thought were relevant to both identify the current context, the current outcomes, and prioritize intervention for the future, and the ability to measure those over time. So this course started in 2018. We had that needs assessment. We're going down that figure on the left, the 5 themes that we mentioned, and then we had a 9-week course held on Cure for Kids, and we had 8 institutions from 8 countries participate. The countries in red in the map on the top right are the countries that were included. We had 36 participants that completed the course, and the course, included pre-recorded lectures as kind of theoretical content. We had important, valuable readings at that time. The 2016 WHO classification, for example, was one of those. Discussion forums were both online in an asynchronous way, but also online discussion, talking about cases, talking about barriers to care, and then each team had to develop a research project, and this was a mechanism that they could use, put into effect some of the newly gained skills in research and quality improvement, but also a way to galvanize those teams. And then based on those 36 participants, we invited 20 participants to come to Memphis to St. Jude to have a 7-day workshop, and there 7 institutions from 7 countries were represented, and that included all the subspecialties that you see depicted on the right. And this experience we published in Cancer last year. And when we were thinking about evaluation of this course, we went back to some of the basic concept of medical education and evaluating interventions. There's a 4-tiered structure proposed by Kirkpatrick. The first and the most basic being reaction is, do you like it? Which is important, but ultimately not the most advanced way of evaluating intervention. Learning is knowledge. And then what we wanted to gear more of this intervention tool was behavior. Results is hard to address when we are talking about clinical outcomes. So these are some of the results that we had. We had an improvement in knowledge in the 5 categories that you see on the left, and this is based on pre and post test, statistically significantly higher level of knowledge. And then in terms of behavior, and that's the figure on the right, and this is self-perceived behavior, we saw a positive impact of this course as well. As mentioned before, the objective patient-based results were not captured, but as I'll mention in a second, we have, based on this course, now have mechanisms to do that. And that is because, from a very honest perspective, this course was more about everybody learning from each other. And this is both from the St. Jude side, that we're more the facilitators, but also every expert that came from across the world had a lot of valuable insight to provide to the colleagues from across the world. So 2 of the centers started multidisciplinary tumor boards for pediatric CNS tumors as a result of this course and their project. And then importantly, the team that came to Memphis in a very organic way came together as a team and created this GAPNO group, which is the Global Alliance for Paediatric Neuro-oncology. And for the past 2 years, and this is since the end of the course, or almost 3 years now, we have had continued engagement. We have a couple of publications out of it. That first one at the top came out in JCO Global Oncology, which was basically a description of the workshop and a lot of the discussion that we had there. And that was a description of that. And then each of the groups have had some publications and presentations at international forums. So that was the experience from 2018, 2019. And then we currently are running the course, and we're just about week 7 of 9 on the online component. And we did an international announcement for this course in the late summer, and we had applications from 60 institutions from across the world. But we had to select 14 countries, and those 14 countries represent 14 institutions, sorry, and those represent 13 countries from across the world. So we have 3 countries from the Americas, Mexico, Guatemala, and Honduras, a representation from 3 countries in Africa, Egypt, Ghana, South Africa, 1 Eastern European country in Belarus, and then we have a lot of representation from the Middle East and Asia, as you see in the map. Syria, Kazakhstan, China, Vietnam. We have 2 centers from Pakistan, and then we also have Indonesia as well. So this is a fantastic group. It's a very energetic group, and we are very excited to be running the second cohort and hoping to build experience from that first one that we ran a couple of years ago. So kind of a general concept, at least from my side in terms of conclusions. It's not just about the educational content, but providing the right content for the right people. And this is where kind of that systematic approach that we engaged on, I think, was very valuable. And I think the other point is team-based learning is very important for pediatric neuro-oncology. It's a mechanism to galvanize multidisciplinary teams, to bring them together, be more efficient, have better communication. And then when we think about any intervention, metrics of impact are key. And this is in the realm of some of what Dr. Kadumi was mentioned. How do you engage those primary care providers? How do you engage them so they can refer in the correct frequency, perform imaging in the correct frequency? This is a hard thing. And at least in our world of pediatric oncology, this is in the context where model data estimates that 50% of the children who develop cancer are never diagnosed. So this is a realm that we cannot forget. We see the patients that are diagnosed in front of us as pediatric neuro-oncologists, but we cannot forget that 50% never make it to a diagnosis. And that's something that is, at least from our field, very worrisome. So I think that's, that was my talk. Thank you for your attention. Happy to answer any questions that may have come up.
Thank you very much, Dr. Moreira. I'm just looking through the list to see if we've got any particular questions that have come up. I don't see any. My question to you then is, and the comment that Dr. Kadumi came up before, was that you've got a cohort of people coming through now who are going to potentially act as ambassadors. Have you got any mechanism whereby they can then be assisted in the way that they disseminate the information in their own centers?
That's a really important element. This is obviously a very small group of experts. Sorry, one second. I have a toddler barging in. But yeah, we have to understand that at least our idea was that the people who participate in our course be local champions, right? That they take it upon themselves to engage the primary care providers, to engage the other oncologists, engage the other neurosurgeons. So it isn't just a small drop in the ocean, and that we can, to some degree, make these education opportunities scalable to some degree. Our footprint, whoever may be small if we think about it in individual partnerships, but if we make it with scalability in the essence, this is a way that we can kind of make this ripple effect. And I think the other thing is reaching out to other specialties, I think, is key when we think about pediatric brain tumors.
Absolutely. I mean, it's a wonderful initiative, and I'm sure it will be very successful. It already has been. I don't see anybody with any more questions. Is there anybody who'd like to ask any particular questions to Dr. Moreira?
Just a comment. I think I'm very impressed with the program that you have. The Listserv started what we call the Global Varsity of Pediatric Neurosurgery. This is an online course. The idea is for 1-year course. Once again, we have got 55 world-class pediatric neurosurgeons, and in the first year we have about 90 students, and so I think with the technology and the fact that it's not so expensive, I think the main thing is the assets of the people who teach. I think there's a positive future. Thanks.
Excellent comment.